Hi there. So I picked a patient who unfortunately deals with several disease processes in his everyday life from his heart and his lungs. Just to kind of give you an idea of them, emphysema, your lung tissue involved in exchange of gas is impaired or destroyed. Coronary artery disease, your plaque buildup, which causes coronary artery to narrow, limiting blood flow to the heart. COPD, a lung disease that blocks airflow, making it hard to breathe. CHF, heart doesn't pump blood as well. Bronchiectasis, lungs, airways become damaged, hard to clear mucus. So you can imagine his everyday life is pretty tough. He's an older gentleman who just has a rough time. So the disease I want to focus the most on is the bronchiectasis. And I actually attached a clip that is going to explain it and just give you a better idea of what's going on.
My name is Alan Barker. I'm professor of medicine in respiratory medicine at Oregon Health and Science University, Portland, Oregon. I've been on the faculty and in clinical practice for 41 years. I am involved in clinical research, including rare lung diseases, most notably bronchiectasis. Bronchiectasis is a chronic disease. It starts with a patient who has had recurrent respiratory tract infections, a chronic cough, usually accompanied by sputum production with that coughing. And then the so-called gold standard or key is a chest image, usually one of these high-resolution CTs, that shows findings of bronchiectasis. That is, the damaged airways that are dilated or larger than they should be, and often filled with mucus, or certainly show the thickened walls of inflammation. The HRCT has become such a good microscope into the small airways where this disease begins and evolves that it will be seen virtually all the time on an HRCT. The bronchiectasis patient is elderly, or at least senior citizen age, and they often are dealing with other chronic diseases. Trying to deal with another one makes them particularly difficult in clearing out the mucus and inflammatory debris that is accompanying bronchiectasis. Secondarily, they have frequent setbacks, or as we call them, exacerbations. They end up in emergency departments on average of 2 to 3 times a year. They have hospitalizations anywhere from 1 to 4 to 5 times a year. These are often not short hospitalizations. In the United States, the COPD Foundation and other sources estimate that there's probably somewhere in the order of 20 to 24 million individuals affected by chronic obstructive pulmonary disease. In addition, we've learned over the past 5 to 8 years that they probably have bronchiectasis, as defined by this gold standard test of the HRCT. We're using this chest imaging tool more and more in our COPD population. And as we do more of these studies, we're finding that as many as 20 to 25% of a large COPD population have bronchiectasis. But management should be able and is able to make lives more comfortable for these people. The vicious cycle of infection, inflammation, reduced host defense is part of the issue why this is a chronic disease. But each of our treatments are focused on each of these elements of that cycle in an attempt to reduce infectious episodes, keep the inflammation down, and bolster the host defense. First, we need to pay attention to infection with the use of antibiotics. But the most important part in these patients is getting it out, getting the infection out, getting the possibly toxic mucus out. In many individuals, cough is just not effective. So we need to rely on physical measures. And that leads us to a discussion of airway clearance or bronchial hygiene. We have a variety of techniques that have been used, and the direction has evolved through the years. Some patients find more effective the so-called high-frequency chest wall oscillatory devices, of which there's two main modalities. The pneumatic or bladder type device has been available for almost 30 years. The device requires attached tubing to provide the pneumatic compression. It involves a vest that usually needs assistance to be applied, and it needs, of course, electricity to power the device. And I would say, fortunately, the field has improved vastly. There is a second device available that operates on a very different principle. It operates on a mechanical oscillatory technique. Advantages include its portability. A patient can be and is encouraged to be more mobile, and the number of oscillations can be dialed for comfort, and the areas for directed mechanical oscillation can be adjusted for those areas that need more attention. In summary, the management of bronchiectasis returns us to the vicious cycle in interrupting that cycle. Airway clearance is crucial during the acute stages of an exacerbation, in the hospital, and to be followed during home management as well. Daily, if not more often, following a management strategy are the keys to living a relatively healthy and reasonable life with bronchiectasis.
So my patient is a 77-year-old male directly admitted to transplant on 2/28 for worsening acute on chronic hypoxic and hypercarbic respiratory failure, worsening likely secondary to mucus plugging. He was in restorative care, and the wife requested a bronch, which their response in restorative care was they do not perform bronchs, and they shipped the patient to transplant where the bronch was performed and a lot was cleared out. He has bronchiectasis with recurrent bronchial pneumonia with multiple drug-resistant Pseudomonas. He is a trach patient because of his need for the vent. They may have luck and get him on the trach collar, but it doesn't last long before he has to go right back on the vent because of a work of breathing. He has a history of CHF, COPD, coronary artery disease, emphysema, and he had a heart transplant in 2012. So for my SOAPs, I'm just going to read it in order, SOAP. So starting with S, patient awake but lethargic from sedation. His vital signs, heart rate 100, blood pressure is 128/66, respiratory rate 35, temperature is 98. His ABG, your pH is 7.41, PaCO2 is 55, PaO2 is 126, bicarb is 31.9, base is 8.9, SaO2 is 100, breath sounds are coarse with crackles. His chest x-ray, patient had a progressive bilateral infiltrate, which is radiographically stable, but not new. Patient gets bronched very often because of his high amounts of mucus. At this point, we want to contact palliative care. We believe it is the best choice because we have reached the end stages and all the treatments aren't giving him much relief. So it is time to just let the family make that decision and talk with him about making that decision, because we're bronching him very often, if not every day, every other day. He is getting Metaneb, treatments Q4, and there's just not much we can do for him at this point.